So I think we're going to get started. I'm Christy Collins. I am the president of the MCM Network. Shannon Bennett is here to help with the webinar, and I'm happy to introduce Dr. Bryan Sisk, who's going to do a presentation for us on vascular anomalies in MCM MCAP and in PROS. He is a hematologist oncologist at St. Louis Children's Hospital and the co-director of the Vascular Anomalies Clinic there. And with that, I will hand it over to Dr. Sisk.
Great. Well, thank you so much. Thanks, Christy, for the invite. I'm really excited to be here and talking with all of you. So just to get started, maybe there we go. For disclosures, I do consulting work with different pharmaceutical companies, and really my goal is to try to get them interested and to design good trials for patients with vascular anomalies. Today, what I want to do is talk about vascular anomalies and what the role might be in MCM or MCAP. And just so I'm not sounding crazy throughout, I'm just going to say MCM for the rest of the time for simplicity. I'm going to talk about the possible roles that vascular anomaly centers might take in your care or your child's care. And then I also want to have time at the end where I can learn from your community. And if you have anything you want to ask or anything you want to tell, I study how we improve communication, how we improve access to care. So if you have things that are important for me to know for our teams to work on, I'd love to hear that as well. So who am I and why am I here? Like Christy said, I do pediatric hematology and oncology, but actually my area of expertise is vascular anomalies, and that's the vast majority of the patients I see have vascular anomalies. And then I actually spend most of my time doing research where I try to improve communication, try to improve healthcare access. And we've got a new arm of research trying to use new technologies, AI, large language models, to see if that can help patients with rare disease to find the right doctors and get the right information they need. And, we're at MCM talking about vascular anomalies. And so first, I'll just give a sense of how we provide multidisciplinary care to vascular anomalies, and then talk about how that might or should relate to MCM. So vascular anomalies really require collaboration and multidisciplinary care because there's no one doctor that can provide everything that a patient needs. And so at our multidisciplinary center, we obviously have hemonc, but we have dermatology, we have ear, nose, and throat doctors, genetics, interventional radiologists. And it's not just that we have all of these doctors and their support staff, it's that we all have a specific interest and expertise clinically in this patient population, and we all work well together. It's important that these different professions also collaborate and work well. The other thing that we do that I think is really important, and I think every vascular anomaly center should offer, is we try to be the specialist medical home. Primary care doctors are a good generalist medical home for putting in referrals, but it's not really fair to expect them to understand complex rare diseases. Our goal is that if you have one of the diseases that we manage and you have a question and you're not sure where to go or what questions to even ask, that you can come to us and we can help you sort through that. And sometimes it's things that we treat, sometimes it's not, but it's just knowing that when you aren't sure exactly what's going on or what steps to take, that you've got that specialist that's advocating and that's in your corner. I'm a firm believer that that's really important in vascular anomalies care. So why are we talking about vascular anomalies when we have MCM, which may have vascular malformations, but it can have a lot of other things also. So this is a figure from a paper that we have under review, and this is actually based on surveys that Christy did of your group several years ago, where we analyzed the data. And the questions we're asking, how has MCM affected you or your child, over the course of their lifetime at different time points? And we categorized it, and you can see it's head to toe. But obviously, we're going to be focusing today on vascular anomalies and vascular malformations mainly. So given how complex MCM is, I'm going to start again with my argument that every patient and every caregiver that's managing MCM, you need and you deserve a specialist medical home. You deserve somebody who's going to advocate for you and who's going to help you get the care you need. I know it's not always easy to find these people. I think some vascular anomaly centers will have the clinicians that can do this. Sometimes it might be other clinicians, but just to know that this should not be an extra thing. This is a core of the care that you deserve. So first, I want to take a step back and talk about what vascular anomalies are, what vascular malformations are. So overall, a vascular anomaly is any type of abnormally developed vascular tissue. So that's the big umbrella term, excuse me, of all of the abnormal vascular tissues that can be present or develop after birth. This breaks down into two categories. There's vascular tumors, and this is not what generally happens in MCM, but vascular tumors are like masses or tissue tumors of abnormal vasculature. And these can be benign, like infantile hemangiomas that a lot of kids can get, but they can go all the way to pure, real cancers of vasculature. Um, but what happens mostly in MCM is what are called vascular malformations. And this is when blood vessels develop abnormally. And so these can be simple, meaning it's just one type of a blood vessel that develops abnormally. It can be combined, meaning that there's two or three types of blood vessels that abnormally develop. And it can be a mix of abnormal blood vessels plus other findings, other syndromic findings. And this is where MCM falls into it because there can be all of those other problems that we saw on the previous slide, plus there can be the presence of vascular malformations. And I'm going to take another step back and say things that you all may already know, but I want to make sure that we've said it during this talk. And so MCM is part of PIK3CA related overgrowth spectrum. And I want to give an explanation. This is actually the pictures that I created on PowerPoint and I share with patients in my clinic to explain this. I just want to make sure everybody's on the same page of what is PIK3CA, what is this pathway? So every single cell in your body has to be able to grow. Every blood vessel in your body has to be able to grow from when you're an infant to when you're an adult. But you don't want to grow more blood vessels than you need. And the way our body really tightly controls this is with what's called a growth pathway that gets turned on by a growth signal. And can you guys see my mouse if I'm scrolling here? Okay, so if in a normal cell that's working just the way it's supposed to, if you want to grow a new blood vessel, your body has to release a growth signal. When this growth signal attaches to this receptor here, I've simplified it, but it turns on this complicated pathway. And it's kind of like dominoes. When it attaches here, this hits the next domino, the next one, the next one. And at the end, it tells that cell to grow and make new blood vessels, proliferate, all of that. When you don't need to grow any more blood vessels, your body takes away that growth signal and the whole thing shuts down. All the dominoes turn back up. What happens in MCM and in MCAP and in all of the PROS disorders is that you have no growth signal, but the pathway's still on because there's a change down here in PIK3CA where it got stuck in the on position. And so even though there's no growth signal, it's still on. And I like to think of this as imagine you've got a row of dominoes and somebody's holding that first domino saying, you're not going to flick this domino down and start that pathway. And then somebody just went to the second domino and flipped that one. And that's what PIK3CA is. So even though this first part isn't turned on, when this second part is stuck in the on position, it's going to still be all the time telling this blood vessels to grow, to proliferate, to make new blood vessels. This matters for a couple of reasons. One, because it helps us to make diagnoses when we know the genetics. But two, as we'll talk about later, these different parts of the pathway can be targeted by medicines. And so we'll talk a little bit about alpelisib and sirolimus later. So the other important thing to know about PROS and MCM and MCAP is that this is caused by changes to DNA as the fetus is developing and growing inside its mother. So whenever we hear about genetic disorders, genetic diseases, the one that most commonly comes to mind is what's called germline mutations or germline changes. And I like to break words down. In medicine, we always choose the most complicated terms because it makes us feel really smart, but it's always really simple concepts. So germline just means germ is sperm or egg. So it's a change in the DNA in either the sperm or the egg, which means the mom or the dad had this change. And then when it's passed down, every single cell in that embryo and fetus and every cell in the adult is going to be affected. But that's not what happens in MCM. MCM is different. It's what's called somatic changes or somatic variants. And soma just means body. So it just means that the change in DNA doesn't happen in the mom or the dad. It's not in the sperm or the egg. It randomly happens as that fetus is developing, and one cell picks up the change, and whatever that cell, like this little red area right here, whatever that cell turns into in the fully formed individual, that's the area that's going to carry that change. And so that's why it's a somatic mutation, because it happens in the developing body as opposed to something that comes from the germ cells, the sperm or the egg. And this is what MCM is. To show another way of showing this is it matters not only that you have a PIK3CA mutation, it matters what cell it happened in and where it happened in development. So there might be a patient who has a lymphatic malformation just in one tiny area that's driven by PIK3CA. It might be a patient who has a more, widespread vascular malformation that's also caused by it. Or it can be patients, this is an example of closed, but you could easily put MCM here and say with really diffuse involvement. And it's all driven by the exact same change in PIK3CA that turns that pathway on. The main difference is how early or late in development and what cell picked up that change. So late in development, and this cell is going to be really localized and isolated. Early in development in multiple cells is going to be more diffuse and widespread. So that's why we call them PIK3CA related overgrowth spectrum, because the same PIK3CA change can cause lots of different looking presentations, patients with different types of disorders. And this is showing all of the different entities that have been called PROS or that fall into that PROS. So everything on this screen is driven by PIK3CA stuck in the on position. And here's where MCAP is. And I think this is an important slide for a couple of reasons. One is that there's not always clear-cut lines between all of these disorders. And you can argue about where exactly these lines are, but there are certainly patients who will fall in between, do I more resemble this disorder or that disorder? But the other really important thing is, since PROS has become a term that families can search, I'm worried it creates a lot of anxiety and worry, because there are some patients with PROS that have this problem, but it might not apply to you. So if you look up PROS and you read something about FABA, the way that that presents and the symptoms that presents are totally different from MCAP, even though they're driven by the same mutation. So it's just important that if you're reading information about PROS, knowing that it might not all apply to you, and it's good to talk to somebody about that if you're ever worried about those things. So as we think about vascular malformations, there's really 4 types that have been reported in MCM, the most common being capillary malformations, but also occasionally venous malformations, lymphatic malformations, and rarely arteriovenous malformations. I'm going to focus most of the time talking about the ones on the left, because the arteriovenous malformation is a bit more severe, and it's even less likely to be present. But we split these up into low flow or high flow malformations. And all that means is when you look at how fast, like let's say you're looking at abnormal veins in a venous malformation, is the blood going really, really fast through there, or is it going really slow? Same with the capillary and lymphatic malformations. And this is important because the treatments of a high flow malformation, like an AVM, arteriovenous malformation, are just different, and the severity is different than when you have low flow malformations. But to talk about any of this, we need to first talk about what are the vascular tissues in the body. And again, I might be repeating things you already know, but I think it's important to see pictures and think through in depth about what these different parts of the vasculature are doing. So we know our heart pumps, and it pumps out through the big hose is your aorta that's going to your arterial system, all of your arteries. That is really high pressure blood. That's the garden hose. And that's why if you feel on your neck or your wrist or your groin or your ankle, you can feel that bounding pulse. That's because every time the blood is squeezing out of the heart, it's pushing really hard with high pressure. That's where your blood pressure comes from. But it's carrying all of the nutrient-rich and oxygenated blood, but you can't ever get that from the artery straight to the tissue. So you have to get it down into smaller and smaller blood vessels so it can actually give out the nutrients. And so what it does is it breaks down into smaller vessels called arterioles, and then it breaks down even further into what are tiny vessels called capillaries. At these capillaries, and these capillaries are everywhere in your body. They're in your fingertips, they're in your organs, in your brain, in your muscles. This is how you get oxygen and nutrients to your organs, muscles, every cell in your body. And then this is also how you get rid of the waste products like carbon dioxide that you breathe out. The other thing that's important is when you go to the other side of this, you've lost all of the pressure. So once you go from the really high pressure hose in the arteries, and then you go through the capillary bed, the blue thing here are all your veins, and those are the ones you see on the surface. And if you look on your surface and you see a vein and you touch it, you never feel a pulse. And that's because the veins don't have any pulse because they've lost all the pressure. These are the low pressure parts of it. A couple thoughts here. One is anytime you go from high pressure to low pressure through this system of capillaries, you send out oxygen and nutrients, but you also have, this is where fluid can leak out of your bloodstream. And so anybody who's been pregnant and has seen their ankles swell up, or anybody who's older and knows that if they stand too long, they can get a lot of swelling and edema of their ankles. This is the culprit. It's because the fluid is leaking out in this capillary bed right here. Your body has to have a way of getting that fluid back into your veins. Otherwise, we'd just be a big, soggy mass of tissue and we wouldn't have any blood. So to keep the fluid in our blood, our body developed what's called a lymphatic system. And the lymphatics job is to go here in between all of these capillaries and the soft tissues and act like a vacuum cleaner and just suck up all the fluid in that tissue. It sucks that fluid up and then it brings it all the way back up here and then dumps it back into the bloodstream. So you've got high flow blood going out, you've got leakage into your soft tissues, and then you've got your lymphatics sucking it back up, dumping it back into your bloodstream. So that's the basis of how all of our vasculature works. The reason this matters is because vascular malformations are, pick any of these vessels and make it grow abnormally more than it should, and then you've got a malformation. And so the one we'll talk about first is capillary malformations. And I'll just briefly talk about diagnosis, imaging, what symptoms you expect, and then I'll briefly talk about treatments here, and then later I'll go into a little more depth about treatments. So capillary malformations are actually quite common in MCM. That's the CM in MCM is capillary malformations. Usually these are things that you can diagnose on clinical findings, and just meaning a doctor can look at you in clinic and say that is a capillary malformation. Sometimes they're called port wine stains. They can be associated with other disorders that don't relate to MCM, like Sturge-Weber and things like that. So if you see things about capillary malformations affecting brain development, eye development, that usually doesn't apply to MCM, but it can to other disorders. But as you can see, these are all those tiny little capillaries that just grew too much and bundled up in the skin, and that's why it's turning pink. And if you press it, it will do what's called blanching, meaning you press it and it gets white and then it fills back up pink because you're pressing the blood out. Usually you don't need imaging, like MRI, ultrasound things to diagnose this because number one, generally it's just in the skin and it's not going to show anything deeper on the imaging. And number two, it's something that you can tell with your eyes better than with imaging. The symptoms, so this is something that generally is going to be present at birth and it can darken over time. In some instances, in other adults who have capillary malformations, I'm not sure how much this relates to adults with MCM, but with other adults who have capillary malformations, they can get some thickening of skin over time. They can get little blebs or bubbles that develop and can be kind of irritating or painful. But usually treatment's not needed. If there's concerns about the darkness of it, some dermatologists will do a laser therapy to lighten it. And then if there are big bumps that become irritating or painful, there's a different type of a laser that can be used on those. But more of the time, this is just something to know about, not something that has to actually have something done about. So next up, we'll talk about venous malformations. And again, if you look on the right here, normal veins are supposed to be pretty well straight. But when you get a venous malformation, they become big, nested, tortuous. The blood gets kind of stagnant and slow in here. And that's a venous malformation. They can affect anywhere. So here's the back of somebody's leg. Here's somebody's face. I've seen patients with venous malformations just about everywhere. Again, you can usually get a pretty good idea of diagnosis just from physical exam. But sometimes we will do ultrasound, especially if they're painful, because ultrasound can tell us if there's a pocket there that we could treat with an intervention that we'll talk about called sclerotherapy. An MRI, especially if they're symptomatic, can be helpful because sometimes these are only in the skin, but other times they can be deeply involved and they can, go through muscle, go into bone, things like that. So sometimes MRI imaging is helpful for us to get a sense of how deep and how involved this venous malformation is. Again, just like these other malformations, these are present at birth and they can certainly worsen over time. And even though something is present at birth, doesn't mean that you see it at birth. It might be present but not visible to you, and it won't show up until later when it gets bigger. The things that patients can present with are usually pain, swelling, not able to move as well as they used to, occasionally infections or bleed, like flaring up of the tissue. They don't usually bleed through the skin. That's unusual for venous malformations. Again, we'll talk about treatments a little bit later, but there's ways that we can poke them with needles and inject stuff, and there's ways that we can give medicines. And to give a sense, we were talking about how, especially venous and lymphatic malformations are slow flow malformations or low flow malformations. This is what it looks like. So this right here is actually the catheter. So they stuck a needle in through the skin into that abnormal blood vessel. And these are the abnormal veins that are filling up with the dye they injected. And we'll show you a fast flow lesion or a high flow lesion later, but this is very characteristic of slowly filling up these kind of abnormal blood vessels. And that's what a venous malformation looks like. Lymphatics look similarly, except for they're more bubbles rather than these longer tubes. So speaking of lymphatics, again, your lymphatics have to be there to suck up all the extra fluid that's being released into your soft tissues. And so normally they look like this. They have these little ends that we call capillary or lymphatic capillaries, and their job is to suck up the fluid and drain the fluid back. When you get a malformation, it can bundle up and again create these big cystic structures. And so when we talk about lymphatic malformations, it's really broken into two categories for simplicity. One is macrocystic, which just means macro means big, cystic means bubble. So big bubbles or small bubbles. And so on the left here, you can see that's bigger and bulbous. And if you did an ultrasound of this, you would see a couple of kind of big, almost like big water balloons in there that are all filled up with fluid. When you look on the right here, you can see these tiny little bubbles, and these are actually the lymphatics that are growing through the skin, and they're tiny little microcysts or small bubbles. And for patients with these, they can actually pop and leak, and they're not dangerous, but they can be irritating. The reason it's important to know between these two is that sometimes you can treat these guys here with just like a topical ointment. A topical sirolimus can sometimes help, or sometimes systemic therapy, but you can't really inject these with agents like you can bigger bubbles. So these ones, imagine this is a big water balloon. You could easily imagine putting a needle in there, draining out the fluid, and then injecting an irritant. And we'll talk a little more about that in a couple slides here too. These symptoms that patients present with, if it's this on the right here, the small bubbles, you can have pain, irritation, leakage, occasionally infections, bleeding. If you're on the left, you don't usually have bleeding outside of the body, but you can get bleeding into those bubbles, into those cysts, and you can get flares that are infected or bleeding or just irritated. And you can imagine having this, even though they're relatively soft, it can get in the way of using your body parts the way you want to. So this person might not be able to put their arm down as easily. And again, sclerotherapy is one of the interventions, medical therapy, and topical treatments. And we'll talk in more depth about those. So those are the low flow malformations. High flow malformations are arteriovenous malformations. And these are different because all of the other ones, the blood was going slowly through here. Here, remember we said when you're going from the artery that's really high pressure, that's the garden hose, it loses all that pressure here and gives out its nutrients and then slowly, oh, I'm sorry, here, and then slowly drains back through the vein. When you have an arteriovenous malformation, it's when your artery is connecting more directly to your vein and skipping these capillaries. And what that does is a couple of things. One is it sends that blood really fast through this nest of abnormal vessels, which means that they could potentially bleed or they could become inflamed or irritated. The other thing, and if they bleed, when you have a high flow lesion bleeding, it can become dangerous because it's pumping blood out so quickly. The other thing is if you have a bunch of these abnormal blood vessels, these ones are not able to give oxygen or nutrients to the tissue. So you can get what's called vascular steal, where it's supposed to have this, but all of the tissue around this is not getting any nutrients because it's just skipping it and going straight to the vein. So the treatments for this are a little bit different. The symptoms are often pain, swelling, decreased mobility. Depending on where it is, you can sometimes get even destruction of the tissue. So these sound really scary, but the most important thing is that the vast majority of time when patients are referred to me as having an AVM or having an arteriovenous malformation, they don't. For some reason, a lot of clinicians out there will use AVM as a catch-all term to say you have a vascular malformation. And they don't recognize that when they tell me AVM, that puts my alert level high. So it's unlikely if you have MCM, you're going to get an AVM. If you are ever diagnosed with an AVM, it is imperative, it is really, really important that you talk to somebody who has expertise and specialty in vascular anomalies to make sure you actually have that, because you don't want to carry that label without it actually being that treatment or that disease, and you want to get the appropriate treatment because it's different for a high flow AVM versus the others. And so just to show the differences here, so this is the same thing, injecting the dye into the blood vessels, and look how fast it fills. You inject the dye and quickly everything is full. So that's really indicating it's a high flow arteriovenous malformation. Here's an example again. Look how slow this guy fills. You fill, and it's just in that kind of lake right here of these big tubes. But this one, it's spread throughout everything in seconds. So you can just get a sense of how quickly versus how slowly that blood is flowing. Now, what's important with all of these vascular malformations is what do you need to do about them? And what's really, really important with all of these vascular malformations is that what we need to do to treat them is really directly related to how they're affecting your body. So if they're not causing any functional impairment, they're not getting in the way of what you need to do, and they're not affecting your quality of life, we don't need to do anything. The low flow malformations are not dangerous in themselves. They're just a nuisance that can cause problems that we need to address. And we don't have cures that make them go away. So doing a treatment just because we can isn't a good idea unless we have a high suspicion it's going to make the life of the patient better. When we talk about functional impairment, we're thinking about the key functions your body has to do. Like if there's a big malformation in your airway, you can't breathe. If there's a big malformation in your mouth or your esophagus, then you can't eat. If it's pressing on your eye, then you can't see. If it's affecting your coagulation, your clotting and your bleeding disorder systems, if it's pressing on your kidneys, this is what we talk about functional impairment is it creating an effect where it's preventing your body from working the way it's supposed to? And those are big deals, but those are also pretty rare. The more common problems with vascular malformations are that it's giving you symptoms, that it's affecting quality of life. And so most commonly, it's going to be chronic pain, swelling, flaring, infections, also psychological distress, inability to do things that are really important or valuable in your life. And this is not to say that symptoms and quality of life aren't as important as functional impairment. They're both really, really important. But when I see a patient and we talk about treatment, we really think through how is it affecting you. And we do one of four things. We do conservative management, we do medical therapy, we do invasive therapy, or we say we're going to monitor and look for long-term complications. If I have a patient who comes in and they say they're having absolutely no symptoms from it, that's my favorite encounter because I can just give them reassurance and say, why don't we check back in a year? Call me if something is going wrong. If a patient is really having symptoms from their malformation, then what we do is talk through how are these malformations, what symptoms are they causing, how much is that affecting your life, and what would success look like if I told you I had a medicine and you told me in 3 months it was working for you, what would working mean? What would it mean that it's going to be making better for you or for your child? And if we can figure out exactly what the symptoms are, then we can decide based on that, based on imaging, whether it's better to do a medical therapy or an invasive intervention. For medical therapies, we have vincristine and interferon. Those are old therapies. We don't really use those anymore. It's really almost all targeted inhibitors now. And for invasive, for vascular malformations, it's really almost always sclerotherapy. There is a potential role for surgery, but not a huge role. It used to be we would always cut these things out, 20, 30 years ago, and then they scar and they bleed and then they grow back. So now more and more, we're only doing surgeries on select patients with specific problems that we think we can make better. Otherwise, we will do, sclerotherapy or other medical interventions. So we'll talk about these in order now. So first, I am not an interventional radiologist, but I understand the pictures enough to give you a description of what it is. So interventional radiology, these are specialists who trained in radiology, and then really their training is to do imaging and put a needle anywhere in the body that they need to. That's really what interventional radiology does. So in this case, here's an example of, say, this is a venous malformation, like we saw. Their job is to do some type of imaging so that they can get this needle and this catheter directly into that abnormal collection of veins. They puncture it. Then what they'll do is they inject an irritant. The fancy term for irritant is sclerosant, and that's where sclerotherapy comes from. Sclero just means scar. So what it means is they inject an irritant to get this thing to scar down. So after they inject that irritant, usually the patient will get pretty inflamed and tender for about a week, week and a half. And then after, as a result of that inflammation, the sides of those abnormal blood vessels kind of get stuck to each other and they scar down and shrink down. So that's the goal of sclerotherapy, is taking this lesion here, inflaming it so that it shrinks down. It doesn't go away, but it can't fill up with blood anymore or lymphatic fluid. And here's an example. Now this is pictures of actual sclerotherapy. These are actually lymphatics. So to orient you, these lines right here, this is the needle. This is the catheter right here. This big black circle, that is the big bubble, that macrocyst. Whenever you see big black stuff, that usually means it's like a fluid collection. So this is all lymphatic fluid. It's a big bubble. What they do is they drain off as much of the fluid they can. Then here's where they're injecting that irritant. And once they inject that irritant, that sclerosant, this is following up a few weeks later where that big bubble is gone and it has shrunken down, and now what's left is these smaller bubbles here that aren't causing as much problems. So that's how sclerotherapy works. Again, it's important to recognize that an interventional radiologist can put a needle just about anywhere in the body, but we maybe shouldn't. So it really should be driven by symptoms. As we talked about, surgery doesn't really help that much because we can't really do a complete resection, a complete excision. We can't cut out all of the abnormal tissue because who knows where the normal blood vessel ends and the abnormal blood vessel begins. And to take out everything that we thought would potentially be abnormal would be really, really problematic for patients. So generally, we don't do this unless there's a good reason. And then there are other techniques you might hear of, like CO2 laser, where it can kind of resurface and get rid of abnormal blood vessels on the surface of the skin. Thermoablation, that's a fancy term for burning or freezing tissue. And again, there's particular reasons to do those, but they're less common. But what I do and what I think is the most interesting is targeted medical inhibitors. And if you remember this pathway we talked about, this is why genetics really matters, because with this, we've identified different treatments that we can use for some patients. And I'm just going to tell the story because I think it's really interesting of how we got here. So this was a slide from Denise Adams. So back in 2010, 2009, we didn't really have any treatments for these patients with vascular malformations or vascular anomalies other than just giving them chemo and hoping stuff worked out. This was a patient with a vascular tumor called KHE, and you can see how swollen and red and irritating this looks, and concerned that baby might lose the leg. They found out that mTOR might be activated in this pathway. So this is the first patient that ever got sirolimus for vascular anomalies. And look at the response. And then the latest update I heard, the patient is, I think, 17, 18 years old and is still doing really, really well and has been off of sirolimus for a long time. So based on that, they said, okay, we still don't know what's causing these diseases, but let's treat with sirolimus. We've got 6 patients, and they found that all of them responded to therapy. So then they did a clinical trial. Again, this was before we knew anything about about the genetic drivers of disease. We just knew these patients had vascular anomalies. And so they treated 61 patients, gave them sirolimus for a year, and had a response in 47 of those patients. 3 of them had stable disease and only 7 progressed. And these were patients that didn't have any other treatments to offer them. Now, what happened right around that time also is that's when we figured out that PIK3CA was driving a lot of these diseases. And so the next drug to talk about is alpelisib. And I'm sure many of you have heard of alpelisib. So PIK3CA or PI3K right here, that's specifically blocked by alpelisib. And so this was first used in vascular malformations in a French cohort in 2018. And so this is a patient that doesn't have MCM, has a different disorder, but you can see how from day 0 to day 180, it doesn't get rid of the disease, but it makes it much less burdensome. And they got narratives where patients and caregivers told their stories that also demonstrated dramatic improvements in how they were feeling after they started taking medicine. Now, the caveat here is that these were like the sickest of the sick patients, and it's not guaranteed that this is going to be the case for every patient on alpelisib, but it was important. And this was actually, here's another example of important responses, not to getting rid of all the symptoms, but making it much more functional for the patient. And this led to approval of FDA of alpelisib. And so, with this, there's now clinical trials going on to test this in other populations. There's also drug companies that are developing other drugs similar to alpelisib that block PIK3CA in slightly different ways. But it's important and exciting that there is investment in our patients, but we need more. And we can talk about it afterwards, but we also need to make sure we are finding ways to include MCM and MCAP in these trials. And a lot of them are not including them unless they have a vascular malformation. So that's another issue that we need to work through. So this is all great and it's exciting. And I'll just take a couple of slides here to talk about some of my other research, because I'm a firm believer that it's great to develop new treatments, but they only matter if you can access them. Knowing that there's a treatment that you can't get or you can't learn about or can't get prescribed, it's not going to help you. And again, I think this is where figuring out where your multidisciplinary team can be, who can be a person to help you advocate or navigate this care is important. And in part because we've done some work looking at vascular malformations and including a couple of MCM patients in this population. We identified lots of factors that influence your ability to access care. So things like characteristics of the individual, characteristics of the clinical scenario, leveraging social networks and advocacy groups, luck, privilege, but especially the healthcare system and the barriers that's providing. We did another survey where we looked at all of the vascular anomaly centers in the country, and here's what we found. Like, look at all these gray areas where there's states that have no multidisciplinary care. And also to note, every PIN is a place that says they are a multidisciplinary program, but not every multidisciplinary program is created equal. And so I can look at this and say, that's interesting that they call themselves a multidisciplinary program for some of these. So really important that even with all of these programs, there's still huge swaths of the country that have nothing. And not all of these are providing the same care. Through another set of research, we found the factors that are really influencing how you access care, the things that get in the way, is not having knowledgeable or expert clinicians that you can access, or even knowing where to look. Not having the ability to travel, because the only center that might have the expertise might be, 100 miles away, 400 miles away, 3 states away. Not being lucky. A lot of people found expert care because they happened to bump into somebody who knew somebody and things that they had no control over. And then we haven't talked much about this, but the other challenge is being an adult. When you make the bad decision to be an adult, suddenly it becomes even harder to find expert care, because there's just not that many physicians with expertise in adult care who have developed interest or expertise in our patient populations. So that's the sad stuff. But we did find some positive things. So we have studies going on right now where we found leveraging relationships with primary care doctors and clinicians can potentially smooth the pathway for some of these patients. Improving communication, improving knowledge directly to patients and families about what these disorders are, giving them, the enough language so that they can search around, giving them, support in how they find these multidisciplinary centers might be helpful. And we're, every day looking for other factors that we can leverage to improve that ability to access care. But it's not perfect, and there's a lot of problems, especially in MCM right now, to get the care that you need. And I'd love to hear more and learn from all of you about this. But again, I'm gonna end with the point that I started with, that uh, every patient with a rare disease, every patient with MCM, every family managing this really deserves to have a specialist medical home and having people that are advocating for you. And I know that many people are looking for this and aren't finding it right away, but don't give up, and just know that it's something that you deserve. And with that, I will pause. Happy to answer any questions, hear stories, hear your insights. Just happy to be here, and thanks so much.
Thank you so much, Brian. That was fantastic. Um, I don't have any questions in the Q&A yet, but fortunately, I have lots of questions or things that I would like you to address. There are two things that I see in our patient population that I think overlap with vascular anomalies, but are not necessarily recognized as such. And I wonder if you could talk about the what happens with cellulitis in vascular malformations, because we have patients who I think don't identify as having vascular malformations aside from maybe the capillary malformation. But cellulitis pops up in our population a lot. The other one is pyogenic granuloma, happens a lot in our population. So if you could just maybe address those two things. I think the cellulitis one is a little more important to me, at least.
Yeah, absolutely. So pyogenic granulomas certainly can develop. They can be driven by PIK3CA also. They can bleed, they can be irritating. Usually the treatments for those are you can sometimes do ointments, but usually it's going to be finding a knowledgeable dermatologist that can address those, particularly annoying lesions with excision or laser therapy or things like that. Um, for what cellulitis, what's really interesting with vascular malformations is we know that vascular malformations can get red and inflamed. Sometimes we don't know why. So we call them flares, because sometimes a flare can be that it's like, if you have a lymphatic malformation, for example, it might actually be infected. It might be bleeding into itself, or it might just have inflammation and irritation. And we never know exactly what it is. So we call it a flare. And generally, we'll approach it by saying, let's treat it as an infection. And if it doesn't get better, we'll treat it as inflammation by giving some steroids. You can get certainly you can get irritation, inflammation, infections of capillary malformations. What I'm not sure about in MCM is whether it is the capillaries themselves that are getting infected or leading that tissue to get infected, or if there's something else about the way PIK3CA is affecting the body that just makes the skin susceptible. But a lot of times they do overlay the areas that they've got prominent capillary malformations. So I don't know, other than to say I would always, especially because some patients with MCM can also have immune systems that don't work exactly like they're supposed to. And so I am always on the lookout to say we should treat this as an infection rather than waiting to see what happens.
Okay, thank you. Yeah, I think, well, at least what I see is that when this is happening to people, it's not necessarily over an obviously involved area.
Mhm.
So, but I appreciate your uncertainty about it because it seems uncertain. Um, okay, we have a question here. My granddaughter, 10 years old, has an extra vein in her femur. Their medical team has said that it is a clot risk, but has not made a plan for taking care of it. Should we be concerned?
So that's a good question. It all depends on so the risks of developing clots. There's a couple I can't give you all the answers, but I can give you the questions to take back. When you think about clot risk, there's two different types of clots you have to think about. Is it a risk that it's a clot that's going to connect to our big deep veins? Because if that's the case, that's where those can travel to your lungs. So, but what's a lot more common in these abnormal veins is to have small clots that stay kind of in the superficial veins that can cause pain and symptoms. So I think the first question is this a vein that is at risk of a big deep clot or just a superficial clot? I think the second question is um, what the risks would be of doing sclerotherapy, because you can close down any vein and kind of inject it and scar it down. But what's really important is making sure that vein isn't the only way that blood is draining back. And so a lot of times before they will do procedures to close things down, they will think about, can we get to the vein and what is that vein draining? And if we block it, is it going to improve things or make more problems? And so it could be sometimes that it's a clot risk, but it's either not feasible to close that vein down or it would cause other problems. But those are the types of questions to really ask. And I can't give a lot of specifics without seeing exact imaging and all that, but I think your team should be able to walk through those types of questions with you.
Bryan, is there a role for blood testing in that kind of evaluation for thrombosis?
It's a good question. So when we test the blood, if we want to know how much clot is built up in your body, we can do something called a D-dimer test. And to explain what a D-dimer is, whenever everybody's seen us, you get a cut and you get a scab, and then eventually that scab goes away. And so our body has really fine-tuned balance of making clot and then tearing that clot down and chewing it up. So the second you make a clot, your body is already starting to take little bits out of it so that it goes away over time. Every little bite that it takes out of a clot is called a D-dimer. And so if you do a blood test and see a high level of D-dimer, that says that you've got a lot of clot in your body that it's taking little bites out of. So it what's tricky is that D-dimer is really non-specific. So any patient who has clot in their body is going to have a high D-dimer. Um, Patients who have abnormal veins and venous malformations at baseline are going to have high D-dimer, and it's not clear is that from lots of small clots or big clots, and you can't really tell that without imaging. So if it was totally negative, it would tell you you don't have a clot at this moment, if the D-dimer was totally negative. If it's positive, it could be that there's a clot in that vein, or it could be any of the other abnormal veins in the body that have that clot.
Thank you. Would red light therapy be beneficial for targeting the malformations?
It's a really good question. So I'm not an expert on red light therapy, but I have talked to some people who are experts. Um, I can tell you there's no studies that have been done on vascular malformations about red light therapy that I'm aware of that have been done with rigor. Um, when I've talked to people who, like my colleague who does lasers and understands the physics of light, he will talk about how there are particular setups and particular ways of doing red light therapy that can be beneficial. And then there's also a lot of marketing where they're selling some forms of red light therapy that aren't strong enough to actually have an effect. So it really all depends on exactly what they're using and how they are promising you, what they're promising it'll do. It should not be dangerous. There shouldn't be any major downsides or risks that I'm aware of. But I think whether it would help, I don't know that we have evidence for that. And just
Thank
make sure you're careful if somebody is saying, just give me more and more money and we can give you more red lights. Just protect yourself against the charlatans.
About capillary malformations, you said they usually get darker over time. In my son, they've gotten much lighter over time. Does that mean anything diagnostically? Has anyone else with MCM seen them get lighter?
So when I was talking about the capillary malformations, that is in the general population who has capillary malformations, they can darken over time. In MCM, I don't know. I would actually ask the community what you guys have all seen.
Yeah, I actually think that this characteristic is associated more with GNAQ.
Hmm.
And I wonder, I mean, I don't really see them getting dark and coarse the way that you
Yeah.
see if you look up, say, Port Weinstein
Hmm.
online. But it's a big concern when you have like a new baby and you think their whole body is, covered. And do you think you see them progressing and getting darker in other PROS patients aside from MCM?
So in other PROS patients, they seem pretty steady. You may be right because the GNA. So other capillary malformations that patients can get that are more plaque-like and thick, are usually driven by something called either GNAQ or GNA11, which kind of turn on a different pathway in a similar way. And so it could be that turning on that different pathway is what causes it. I've had patients with MCM that were born with really, really pronounced capillary malformations, and they've gotten better. Those patients have been on alpelisib. So what I'm not sure of is this because alpelisib is doing something, or is that just the natural history of what's going to happen to them? But I don't know.
I appreciate you saying that you're not sure. I think what we see in the community is mostly them fading, but not always. Um, and somebody else is saying very much lighter over time for us. So just for the people attending, I have questions both in the chat and the Q&A, and so I'm going to switch to the chat now. Are
And I
there?
think as you're doing that, one thing to say is the reasons I have to say I don't know so much is because nobody is studying this stuff. And
Yeah,
so
I
we
really
need to know
appreciate
these
you saying
answers.
that, Brian. I mean, I think that, yeah, thank you. I think it's good you're saying you don't know.
My
Um,
humble bill for the day.
are there ever case managers involved in vascular anomalies clinics? As a previous case manager, I feel like that would be a great service to offer.
That's a really great idea. Every vascular anomalies clinic does things a little bit differently based on what resources available and offered. So at our center, we have the case manager role has been driven predominantly by nurse coordinators. But I think as we continue to grow, we're going to lobby to say, give us an actual case manager to help, especially with patients that are really struggling. But it's a one of the things, so through some of my research, one of the things that we want to do is actually standardize what we call multidisciplinary centers so that a patient looking online or a caregiver looking online can tell the difference between, four people who have seen five patients versus a center that actually has expertise and interest and infrastructure. And it could be something like a case manager, say that becomes an essential component to have a multidisciplinary designation. So I love that idea, and I'll carry that forward in our work.
I think a lot of them, I was just say some of them do have case managers, some of the larger ones. So the next question, this person is scheduled to see the Vascular Anomalies Clinic next month for the first time. What should I be asking? I know a lot of people are on VJoyce. I
Mhm.
had not seen the need for this in the past, but now I'm wondering if it's something I should be asking for. When would this be something that we definitely would want to push for?
Great question. So I think there's a couple of things I would really encourage you to ask when you go to that visit. One is, who do I call when I have a problem and I'm not sure exactly what to do? And the ideal answer is they say call us. But you should at least put it out there for that to give them the bait to say that they want to be your advocate. The other thing that's really important when you think about VJoyce, alpelisib, is really go into that visit thinking about how the MCM is affecting your child and what ways you might be able like what would improvement mean and talk through which of those things that you want to see improved does that doctor think might happen with alpelisib. The ways that alpelisib in the patients I've treated with it, the reasons that we've started it, one is for vascular malformations that were causing issues. One was a patient that had persistent low blood sugars that we treated for. And one was because a parent was really interested in seeing if they would, they had some, you blood vessel issues, but we're also really interested in whether it was going to affect cognitive development in any way. And so those are the reasons we've tried it. Again, we don't have clinical trials to prove any of these things are better, but it's really about if they say to start a drug or if you want to start a medicine, it's really thinking about what are our goals and how do we know if we're reaching them? And that's what I would encourage you to talk with them about.
You just talk for a second about what kind of monitoring is involved when somebody goes on a drug like alpelisib or
Mhm.
sirolimus. I think that isn't always obvious to people that there's.
Yeah, absolutely. So we can talk about them in order. So for alpelisib, the monitoring, depending on there will be routine clinic visits. Depending on the center, some will say monthly visits, some will say every 3 months. People don't usually go much beyond every 3 months initially when you're starting alpelisib. The way that I do it is I will get baseline labs to make sure that all of the organs are working and it's safe to give the medicine. And then I will check labs again in a month. And if everything looks good, I'll check it 2 months after that. And then I'll check labs every 3 months unless there's a new complication or a new problem or concern. If there's something that we're trying to change that we can see on imaging, like we have a malformation that we're trying to want to see if it shrinks, I might do imaging before and then maybe after a year or so. Um, but that's really what the monitoring looks like. And then when you come in is going through whatever side effects you're having and thinking about those issues. With sirolimus, it's a little different because with sirolimus, you can actually measure how much is in the blood. And if everybody on this call took the exact same dose, we would all have different levels in our blood. And so sirolimus, we have to actually measure the blood to figure out what is the right dose for any particular individual. So with that, it ends up being usually monthly lab draws to make sure that that dose is in the right range. And then eventually over time, that might space out to every 3 months. But still, we're seeing patients usually about every 3 months long term on those medicines.
Thank you. I'm going to jump ahead of some of the questions because there's something I really wanted you to talk about, and that's the
Yeah.
role of puberty. And I think that in the vascular anomalies world, it's sort of common knowledge that things can accelerate at puberty. And so that's not common knowledge, I think, for our population. Could you just address that a little bit?
Absolutely. Yeah. So in vascular anomalies themselves, number one, they seem to be hormonally responsive, meaning that they seem to get more irritated when patients go into puberty and especially when women are pregnant. That's when they can get more inflamed and grow a little quicker. Um, and so we will often talk to families that, hey, this thing might have not been causing a problem until your kid turned 8, 9, 10, 11, and you started developing, and then you're having more infections, more flares, more irritation. And we think that might be related to, we think it's the hormonal effect on the blood vessels, but it could be something else unrelated that is also happening during puberty. So that is a really common thing. And we'll even consider that when we're talking about doing a treatment. We will talk about maybe we're treating you right now. Maybe we want to time this treatment that we'll keep it going until puberty is done, and then we'll try backing off to see how you're doing. So I suspect that there's similar issues in MCM. Again, we need a study to actually map that out, like maybe your registry and getting some natural history data over time. But I suspect that there could be similar things related to puberty in MCM.
Thank you. The part of the reason I mentioned it is I think that our vascular malformations in general are a little more low key, and sometimes we don't know that they're there at all.
Mhm. Yeah,
And
that's a
then
good point.
they
The first time they pop
emerge.
up might be puberty that you notice them.
Thank you. So this is, I think, sort of a comment. I found that the vascular anomalies clinics where I live are not interested or willing to see my son due to the neurosurgical monitoring needed for him with MCM, and also don't seem that comfortable with PIK3CA patients at all. Also not interested in seeing him because he's an adult. So it seems that a medical home for all of his issues is difficult, and I'm the case manager for multiple facilities and specialists that don't communicate. Any ideas or suggestions for this age group? This is a young adult. Or why particular vascular anomalies clinics don't want to treat those with brain involvement?
Um, Really good, really hard question. What I can say is, the multidisciplinary group is only as good as the individuals that make it up and their willingness to fulfill roles for patients. So, in general, and this is hard advice to give too, because you might not have freedom to do this, but in general, if it's not working, there are other vascular anomaly centers that you could look into to see. There are some that will see all ages. There are some that do have very invested and interested clinicians that want to help manage these patients. So I don't know how to change that. I could change how they're interacting with you, but there certainly are places, and I know I have colleagues that are interested in willing and happy to take care of these patients. The other thing, and we'll have more about this probably in a couple of months that maybe Christy can send out. But I'm leading the development of this thing called VACs or Vascular Anomalies Access, and the goal is that we'll be able to help clinicians in the community or in other areas who either don't have expertise or don't know where to refer or how to refer, and also helping families to look where centers are that see patients. That resource is going to be going live in the next probably month or two. And that might be a resource where you could go to your primary care doctor and say, hey, can you help me think through which of these we might be able to, touch base with a refer and see if we can find the right doctor for us. But unfortunately, I think some of it's going to be, either you're doing what you're doing, which it's an amazing work that you're doing navigating all of this care, and it's not fair. The only other option I see, though, is finding another team where there's somebody who is competent and willing to fulfill that role for you. Chrissy, if you have other comments to add on to that.
I don't. I just would clarify that Vaxos is going to be for like your doctor to reach out with questions to a group of experts. So it wouldn't be you reaching out directly, but for your
Yeah,
doctor.
it'd be doctor reaching out, but we will have resources on there where you can go and look and see on a map where all the vascular anomaly centers are and whether they see adults and children or just children.
Yeah,
So it's at least a first step. And then we've got a grant in, we'll find out about in the next month or so, whether we can engage with patient communities and really build up the direct to patient facing materials as well.
great. Um,
Hmm.
okay, I have I'm sorry. So I'm just going to read Jessica's comment. I was sort of looking for the question, but I think some of this is just communication to you, Brian, because you care. This is hello from Florida. I'm the caregiver for my younger sister. She's 28 years old. She had a stroke in her teen years. Um, they connected with an IR in Orlando when she was 19 years old, and she had a full body MRI to assess her vascular system. And thankfully, she does not have vein issues outside of her overgrown abnormal brain structures. I felt relieved. She has not been able to access some of her specialists from the pediatric world because she's over 21. We've struggled to find specialists willing to help her as an adult. Providers do not interact with one another, leaving the burden on me to coordinate her care. Is there a multidisciplinary team anywhere for adults? I mean, there are some, so I'm just going to say here, part of the issue here is that this is a patient that is very much a brain patient. So not only do you need a multidisciplinary team, but you also need one that incorporates the neurosciences care needed. And that might not be, I can't think of any place.
Yeah, but so whether there's a preformed team with that, but also some of it, I mean, the dirty secret is that it also just depends on how much the doctors are willing to work with each other. Like I don't have a neurosurgeon in my core multidisciplinary team, but I work with the neurosurgeons all the time, and I make effort to have a communication with them and say, we have this patient, let's have a 10-minute discussion. It's just, with all of the other things that we do in our jobs, it's an extra thing to do, and some people do it and some people don't. But it doesn't mean it's right.
So I have a couple of other things that just say thank you. Lots and lots of thanks here, Brian. I had some other questions, but our time is up, and I think I could probably come up with a whole other webinar. But I'll just say that Brian evaluated this data for us. I was going to only call you Dr. Sisk on this webinar. Dr. Sisk evaluated our data for us, and we're talking about other projects to better characterize our population, which we have talked about. There's lots of things we don't know. I mean, sometimes we sort of know in the community, but it's not enough. We need like documented scientific knowledge for these things. We have some uh, plans for a real registry coming up for the MCM network. And so Dr. Sisk has offered to help us with that. And hopefully we can make some good progress on this. So thank you.
Absolutely. It's a pleasure. Thank you so much for all your time.
Right. And thanks everyone for your great questions and for participating and coming. I really appreciate it.